Good morning, everybody. I'm one of the registrars of EMP. I'm going to present on vascular anomalies this morning. In 1993, they defined a classification of congenital vascular malformations. And they define two major categories. So that's tumor versus vascular tumors versus vascular malformations. So tumors are generally not present at birth, with one exception being congenital hemangiomas. They generally have increased endothelial cell turnover. They do show a proliferative phase, and then most of them will show spontaneously involute, with the exception of a non-involuting congenital hemangiomas. Then looking at malformations, the majority of them are associated with a SPIC3CA gene mutation. They are errors in development, and then they are present at birth. Sometimes they might not be appreciated at birth, only become apparent later, and then they usually grow proportional to the child, but they can go through times of rapid enlargement due to bleeding or infection. So in the ISSVA classification, the vascular tumors are further subclassified into benign, locally aggressive or borderline, and then malignant tumors. And then the vascular anomalies, they are further classified as simple, and that's according to the vessel of origin. So it's capillary, lymphatic, venous, arteriovenous, and malformations and arteriovenous fistulas. And then you get more complex lesions that involve two or more of the same lesions. Like a combined lymphatico-venous malformations, is probably the most common in a combined group. And then you get other associated syndromes. So a further classification is usually based on the flow of lesions. And this is important because it helps determining the etiology of lesions when we do ultrasound. So fast flow lesions, so over tumors, usually you've got hemangiomas, fast flow lesions, and then tufted angiomas, and some of the other in your also in your tumors. And then malformations, those are your arteriovenous malformations in your fistulas. And then slow flow lesions, these are mainly your vascular malformations, including your simple malformations, lymphatic, venous, and capillary, and then your combined, which is your usually syndromic patients. So the most common two vascular anomalies are infantile hemangiomas and then lymphatic malformations. Those are, I think, two that's of most importance to us. So looking at infantile hemangiomas, they need to be differentiated from congenital hemangiomas because they are treated quite differently. So congenital hemangiomas makes up about 30% of hemangiomas, and then infantile hemangiomas about 70%. Where congenital hemangiomas are usually present at birth, infantile can be present at birth, but are very small, only mostly appearing 2 to 8 weeks after birth. Congenital hemangiomas are completed their growth at the time of birth, and then involute from there over 12 to 18 months. On histology, they're glucose negative, and they show no response to beta blocker therapy. Whereas infantile hemangiomas show a rapid proliferative phase over 6 to 12 months, plateau phase, and then slow involution. It's usually complete by about 5 to 9 years. They are GLUT1 positive, and they show response to beta blockers. So infantile hemangiomas, they got about incidence of 1 to 2.6%. 80% of them are noted in the first year of life. 3 to 1 female ratio, and then a 60% of them are in the head and neck region. The pathogenesis is multifactorial, but estradiol has been linked to the pathogenesis, and that's postulated by this higher female prevalence, and then also vascular endothelial growth factor. So this is just a schematic that shows, so that I think that there's a hypoxic event in the local tissue hypoxic event during development, within vascular endothelial growth factor and insulin-like growth factor activation and angiogenesis. So clinical features, it's usually a pale macule with superficial telangiectasia. It can appear as a bruise-like area, and then the superficial subtype, they are usually brightly erythematous and appears as macules, papules or plagues. The deep ones appears like a bluish nodule, and then you get combined ones as well. So this is a classical appearance of a deep hemangioma. So one of the things to bear in mind when looking at patients with hemangioma is the face syndrome association. So that's a neurovascular syndrome, and it's known for posterior fossa anomalies, hemangioma, arterial anomalies, cardiac anomalies, and eye anomalies. They've got a very high incidence of airway hemangiomas, I think ranging up to 30%. They commonly have a facial hemangioma that's more than 5 centimeter segmental distribution. These are infantile like hemangiomas that respond to beta blockers. So the reason to be aware of them is that we need to be cautious of using beta blockers in these patients because of the cerebrovascular malformations. They have got an increased risk of stroke, and because of cardiac anomalies, beta blockers might be contributing. So this is a map showing what the segmental distribution of these hemangiomas would usually be. It's usually confined to one of these areas. This is just a picture of the example of the scalp segmental distribution of one of these patients. So moving on, the natural history of infantile hemangiomas is that 80% of them will involute spontaneously without any treatment. So they go through this rapid proliferative phase, which is usually complete by 6 months of age, a plateau phase, and then the involution phase. And because of this, most of them can be treated with watchful waiting and doesn't need any further treatment. But then, should treatment be required, the treatment options include beta blockers, which is the mainstay of treatment currently. But oral corticosteroids can be used as a second line, but they're only useful during the proliferative phase and not after that. Intralesional corticosteroids has also been reported. A few studies report sirolimus use as a third-line agent, and then they can have vascular laser surgery and surgical excision if poor response to the above. So indications for immediate treatment, and these are the ones to worry about, is obstructive hemangiomas, especially ones in the airway, and then ulcerated hemangiomas on the face because of scarring. I mean, large facial hemangiomas, especially when close to the nose and close to the eye, because of subsequent scarring and disfigurement. So the VACCIN guidelines propose the following treatment algorithm. and they say there's a risk of functional impairment, airway, ulcerated, or risk of disfigurement, then you would treat them. If not, then you would not treat them and just follow them up serially. Treatment would start as soon as possible with propranolol at 2 to 3 milligram per kilogram per day in 2 divided doses. Evaluate the response within a month. If they've got good response, you just follow them clinically. If they've got no response, then one needs to either do a combination of imaging and biopsies, look for the GLUT1 receptor on your biopsies to see if there are really beta blocker responses. So you can continue with beta blockers if they're GLUT1 responsive. If not, then you can consider second-line treatments like corticosteroids, sirolimus, embolization, and surgery. So looking at airway hemangiomas, they're quite rare, but we do see them now and then. They're usually subglottic. And then the important thing is when to suspect them is when you've got facial hemangiomas and the beer distribution, these kids usually need to have endoscopy to make sure there's no associated subglottic hemangioma. The faces syndrome, they need to be evaluated for airway hemangiomas, and then any cutaneous hemangiomas with associated stridor. So airway hemangiomas, the medical management is the same. Start with beta blockers, and it must be started as soon as possible. Some reports say that it does prevent patients from surgery, but the research on this is quite sparse, limited to patient reports. And then some centers do use intralesional corticosteroids as well. So surgical options for airway hemangiomas, this is specific as the first line. So open excision with a laryngeal fissure and anterior costal graft is used by many centers. They report about a 90% remission rate. And then other centers use laser surgery as first line, with the advantage being it can be done endoscopically. Typically, it would be either CO2 in the ear or diode lasers, but there's a big risk for scarring with incidence of subglottic stenosis of 25%. These patients usually require multiple surgeries, whereas open excision, you only need one surgery usually. So moving on to lymphatic malformations. So these are structural defects secondary to defective lymphangiogenesis and not tumors. And they're the most common head and neck malformation in kids. So the embryology at weeks 18 to 44, the lymphatic sacs are quite closely connected to the developing venous system. And they first appear as sacs, and then they start disconnecting from the venous system and cannulating by about between week 23 and 56. And once the fetus is born in a normal fetus, then you have the normal lymphatic ducts, which is small channels. But then, and this is a process where they disconnect. So the first thing is the ballooning model, where they disconnect erroneously from the vasculature. And the second one is a bulging model. And then another important factor is that there's no lymphatics in the CNS. So you never get a lymphatic malformation in the CNS. If you find something in the CNS looking like it should be something else. So the PIK3CA gene is postulated as one of the contributing factors to pathogenesis, which is closely related to upregulation of growth factors, stimulating the mTOR pathway, with increased symptomous cell growth. So histopathology, a disconnection between the lymphatic channels, forming these fluid-filled cysts. It's usually protein-filled vascular spaces. There's a normal endothelium thin basement membranes, non-immunohistolystain positive for D240. Should appear something like this. So clinically diagnosing these patients, they can be diagnosed prenatally, when they're quite big, and then also antenatally. They usually present as a fullness and a soft tissue mass, which got quite a spongy and cystic feeling. They're non-tender, and they can have a bluish hue to them. They usually appear in lymphoid-rich areas. So the head and neck area, axilla, groins, and those are the most common sites for them. So clinically, they're slow growing. They usually grow with the patient. They rarely get smaller on their own. If you do see rapid growth, then you need to be worried about infection and hemorrhage into the cysts. And then they induce hypertrophy of the surrounding tissue, which is also contributing to quite a bit of morbidity for these patients. So clinically, you won't find them in the CNS, thrown in the lymphoid-rich areas. So complications of include dental. They can have malocclusion. It can affect the floor of the mouth. But badly, halitosis, poor oral hygiene. Fluid leak is quite a big complication where they're ulcerating the surface of leaking skin plebs. Also, they can cause pleural effusions that penetrate deeper. And then GIT, protein losing atrophy, peritonitis. Hematologically, they can have lymphopenias, thrombocytopenias, and coagulopathy, although it's not that common in lymphatic malformations. Infections, and then obstructive, they can cause airway obstruction, obstructive symptoms on the eye. Orthopedic, and then the big ones is also pain, aesthetics, and functional loss. So they can grow quite big and become quite disfiguring. So imaging, in a few centers, ultrasound would be the mainstay of initial diagnosis for these, and Doppler's lesions will show low flow lesions, but along with a clinical picture with point the diagnosis. Many centers also use MRI, and it's considered the gold standard. MRI is quite useful because it can differentiate solid components from cystic components. It can tell you about how deep it penetrates. Usually it's a contrast scan with fat suppression, and they have a high T2 and signal intensity on these scans. There's no diagnostic role for CT scans, only if you suspect bony involvement. And then previously, lymphangiograms have been used with limited availability, and they don't change the management at all. Classification, truncal versus extratruncal is one of the classifications used, and then very important is the microcystic versus macrocystic, with a cutoff being 1.5 centimeters. That will change management. Isolated lesions versus combined lymphatic or venous malformations, and then localized versus diffuse lesions. So this is just the ISSVA classification. It can be macrocystic, microcystic, but most of them is actually a mixed cystic lesion with both micro and macrocysts. And then the generalized diffuse ones is GLA and the other syndromic types. So common and simple, they usually like localized, isolated to the skin and mucosa and subcutaneous tissue. Deep ones you need to worry about pleural effusions and penetrating to abdominal cavity. Management, in most instances, a multidisciplinary team is advised for these patients. Most of them, if it's not disfiguring and not causing obstructive symptoms, people would suggest watchful waiting. But the head and neck ones, parent often wants some form of therapy, and when sclerotherapy for macrocystic disease has been advised, followed by surgery if a poor responsive for microcystic disease that's amenable to surgery, and then as last resort, sirolimus. So management, just a few non-surgical options is compression, lymphatic massage, hygiene, and then laser therapy if they've got skin complications. So management principles, that's constant re-evaluation to reduce the risk of inflammation and infection, reduce oozing for patients, reduce the risk of damage to vital structures, and decrease fluid volume in tissue and cysts. So again, sclerotherapy, which is the first line of management for macrocystic, the disadvantages is you've got an unpredictable outcome, and only 40 to 80% effective. Swelling is a major complication. They can have significant scarring from it, and then systemic toxicity. Disadvantages of surgery, it can be either complete versus debulking surgery, with debulking being most often embarked on surgery. Surgery can also lead to significant scarring and disfigurement. Bleeding is a big issue, nerve damage, poor wound healing, infection, and then the big thing is a lot of them have recurrences. So the Vascular guidelines gives quite a nice schematic of how to approach these patients. So the first thing would be, once you've got a suspected lymphatic malformation, is the investigations. So Doppler ultrasound would be the first one, with MRI only if you are unclear about the diagnosis after Doppler, or if you're going to embark on surgery or sclerotherapy. And then CT only if there's bony lesions. Mucosal investigations, so endoscopy, depending on symptoms of the patient. So the treatment overview is just that for macrocystic. So for most of them, you first use conservative measures, watchful waiting, and then specialized treatment for microcystic disease is surgery, and then after that, if they're not amenable to surgery, to consider sirolimus. And then macrocystic and mixed is to start with sclerotherapy. So just a note on sirolimus, it blocks the mTOR pathway, and if you look at the mTOR pathway, it blocks the vascular endothelial growth factors, further down the pathway, decreased cell proliferation, and angiogenesis. So currently, it's not the first line of treatment, and although there's groups that believe it should be first line of treatment for these patients, up to 90% of patients show at least a partial response on sirolimus. There's seldom a complete response, but it can often have a good enough response to avoid surgery. It can be used as adjuvant therapy to surgery, starting prior to surgery. There's some studies that show that it does decrease the recurrence rates and complication rates after surgery. And then in one study, they reported a 33% decannulation rate in tracheostomy patients started on sirolimus. But it's quite expensive. It's a month's supply of a 1 milligram tablet, which is a lower dose for some of the patients, is about 3,500 to 4,000 rand a month. So sclerotherapy, there's a range of agents one can use, and they're classified as osmotic, which is hypertonic saline, dextrose, detergent-based, which is sodium tetracyclate, and polydiclonal. These are quite expensive and not often available. And then irritant and corrosive, and that's the majority of people use, is ethanol, bleomycin, doxycycline. And then the mechanism of action, it's injected into the cyst, causes irritation of the endothelial lining with injury, and then the fluid gets aspirated, and hopefully as it heals, the lining of the cyst obliterates. So dosages, doxycycline is 10 milligram per ml, and then bleomycin 0.5 to 1 milligram per kilogram. But there's a maximum lifetime dosage of bleomycin, but it's the most often used in South Africa. So procedure, you aspirate the cyst, you estimate cyst volume. Usually it's done under image guidance, ultrasound, or fluoroscopy. A needle or pectile is inserted. You aspirate to dryness, you instill your sclerosant. There's a dwell time depending on your sclerosant you use. Aspirate again, and then compression dressings. They need to be repeated every 6 to 8 weeks. And then after 4 sessions, if you haven't had a good response, you should reevaluate and decide if you don't need to use something else. It's just showing that where they use ultrasound, where they use fluoroscopy, first injected with a bit of contrast to guide sclerotherapy. Complications include pain, swelling, ulcerations, skin discoloration, infection, recurrence, and bleomycin, a lot of pulmonary fibrosis, and also puts them at risk for secondary malignancies. And then ethanol, if it extravasate, nerve toxicity.
I'm not going to clear in my mind. It's kind of confusing for the topic. Yeah, but I think the management is always difficult, and you have to individualize it, like we said, onto the patient's wishes. I don't think there is any. I think often you're limited by the resources you have, and as well as the surgical expertise you have. But I don't think there is any. Like you said, the macrocystic ones are more amenable to sclerotherapy, but they can also be multiple. And there are a lot of nuances to sclerotherapy. I haven't done much sclerotherapy, which are dictated by the agents you have and what agents you have access to, and the age of the patient as well. And then surgery obviously runs the risk of, like you said, all the potential complications of surgery, particularly of the head and neck. I know that, I don't know what your experience has been, but you don't have much surgery post sclerotherapy. I don't think the case, but it hasn't been a problem because you take it off. No, so I haven't found it stuck around the future. But I haven't done it. Yeah. Any comments or questions on the floor?
Any questions? I don't see anything in the chat.
Yeah, thank you. I mean, the only one thing I want to say, it's purely anecdotal, is one sirolimus does have side effects. I think you have time to go into all of them. It's often not particularly well tolerated by the patients as well in my anecdotal experience. And we haven't seen it just a quick scare. But most young adult we've seen it, and they haven't responded so far.
So
they have developed systemic toxicity.
So yeah, literature is already new, but seems like the younger you start, the better response would be. I think this is why there's a push on some select first line people, to get the patients started at a very young age.
Never from pediatric surgery. Yeah.
No.
Yeah. Okay.
But we used to do in pediatric surgery quite a bit of osteotherapy.
Yes.
And actually worked quite for some patients it worked very well. There's like multiple cysts when you just each session target one or two of the cysts.
You have to do it on the imaging.
Yeah.
Yeah, fine.
Yeah, we usually did it under ultrasound guidance.
Yeah.
Which was quite easy.
Yes.
It wasn't do it.
Okay. Yeah. Thank you, Jaco. Thank you very much.
Thanks everybody.